So as I said, what I would be covering would be a bit of clinical presentation. What is the pathophysiology? How do you select the fluid and how do you administer it? And a bit of blood and blood products, indications and way of administering them too. We need to know that of the dengue infections, only 10% become symptomatic. And of the symptomatic dengue, it is only the 10% that develop dengue hemorrhagic fever and 1% develop dengue shock syndrome. So, what we are discussing, what we are concentrating, and what we are bothered about is this just 10% of the symptomatic dengue that becomes bad, and the mortality in this subgroup is still significant. So, when do you suspect a dengue? So, when you have a child presenting to you with fever, with any of the viral prodromes, a headache, a retroorbital pain, lethargy, arthralgia, or rash, along with or without lab manifestations like thrombocytopenia, a leukopenia, or a rising hematocrit, you should suspect dengue. So, if any two of the following is positive, we should clinically suspect dengue. So dengue can be classified into three. Mild is the symbol is the typical dengue fever. That means it is very difficult to distinguish between a dengue fever and a viral fever. They do not develop complications. They just manifest with fever, myalgia, arthralgia, those kind of things. Moderate dengue has two subclasses. That is a simple dengue happening in children with comorbidities, maybe a congenital heart disease or a liver disease or immunodeficiency. They are at higher risk for mortality, or dengue with warning signs. Both these together form the moderate dengue. Severe dengue is either a severe capillary leak, which will manifest to you with severe respiratory distress or shock, or it manifests to you with a hemorrhage, expanded dengue syndrome. That means when the dengue involves other organs like an encephalitis, a myocarditis, an acute liver failure, or even when you have a severe metabolic derangement, electrolyte imbalances, severe hypoglycemia, hypocalcemia, that is also taken as a severe dengue. So now what is the key pathophysiology? What happens in dengue is, in fact, there is a capillary endotheliopathy. The capillary endothelium gets damaged, and what leaks out is not just water, it is also the protein that is leaking out. So what happens if things leak out through your capillary endothelium? Why do they leak out? It's either because there is a direct invasion of the capillary endothelium by the virus, or it is because of the cytokines that has been produced in response to the dengue fever, which is damaging your endothelium, or it is the antibody that is being produced against the virus, causing an antigen antibody reaction, which is leading to a capillary leak. So, whatever be the cause, among all these three, the antigen antibody reaction is considered to play an important role in causing an increased capillary leak. How does this clinically manifest? This usually manifests with a pleural effusion, ascites, or shock, or interstitial edema. The interstitial edema should never be taken lightly. When a child in severe dengue having massive capillary leak will really appear grotesque. When this baby recovers, they look so thin that it's almost unrecognizable, difficult to believe that it's the same child presenting to you or had presented to you with so much of interstitial edema. And when we say interstitial edema, don't take it lightly. It is not only the cosmetic appearance you're bothered about. Remember, every organ in your body is getting edematous. And as every organ in your body gets edematous, the blood finds it difficult to enter the organs. The nutrient delivery to the organs is hampered, and it causes organ damage. So, interstitial edema is an important cause in the pathogenesis of severe dengue. Now, let us come to the first stage. So, this was a child, 3-year-old, who was presented to a hospital on day one with fever. So, the child was prescribed paracetamol and sent back home with appropriate advice. But day two, the fever was persisting. The child was not taking feed, and the parents were really worried. The dengue outbreak had already started, so they also knew about it. So, they came back to the hospital. And because of their worry, they were admitted to the hospital, and the child was started on Isolite P. Day three morning, the baby had 2 episodes of vomiting, so the IV fluids were not stopped, it was continued. But in spite of being on IV fluid, by evening, the child went in for a hypotensive shock, which necessitated the baby was resuscitated with 2 boluses of 20 ml per kg of normal saline and referred with a documented BP of 90 by 66 millimeters of mercury. The baby hardly took half an hour to reach our casualty. By the time the baby reached our casualty, the baby was still febrile. The BP was 80 millimeters. That means from 90, the BP had now fallen down to 80. The pulses were feeble. The child was looking puffy. Air entry was decreased on the right side. The respiratory rate was 58, and with retractions, and SpO2 was 90% improved. That means you're having a child with respiratory distress in shock. On one side, you can say it's a relatively stable vitals. The child is not in really decompensated shock. It's not an absent pulse situation. The child is not bleeding. The child has a mild respiratory distress without oxygen. He's saturating at 90%. But exactly, this is not the time for you to rejoice. We need to know that his leaky phase has just started. He is going to go for shock again and again. And the capillary endotheliopathy and the leak slowly progresses. And usually, when the child is manifesting to you in a hypotensive shock, he's almost reached the peak of the leak, and he is going to leak for the next 24 to 48 hours. As he leaks and goes into shock, he will require further fluid boluses. When you're going to give the fluid boluses, the respiratory distress is going to worsen, and he will require an invasive ventilation or may later go up to invasive ventilation. And finally, you have a situation where on one side you have shock and you want to give IV fluids. On the other side, you have hypoxia, which is not getting managed by your ventilator settings. And if you try to manage shock, the hypoxia worsens. If you try to manage hypoxia, the shock worsens. So that is literally standing between the devil and the deep sea. Hypoxia, hypotension, and high ventilation.
Madam, excuse me, ഇച്ചിരി കൂടെ ലൗഡ് ആകണമെന്നുള്ള ഒപ്പീനിയൻ വന്നിട്ടുണ്ട്. ലൗഡ് ആകണമെന്ന്.
No, ശരി, wait. Okay. So is it audible now?
Yeah.
So when you have a combination of hypoxia, hypotension, and high ventilatory settings, we need to understand that's a deadly combination. You're literally standing between the devil and the deep sea. So could we have done anything different? We need to remember that we will not reach the shore just because we started early. Dengue complications cannot be prevented by preemptively putting a child on fluids. So what do you do? So if you have a baby presenting to you in the febrile phase, that is day 1 or day 2 of fever, remember, encourage oral fluids. The non-steroidal anti-inflammatory drug which is recommended is only paracetamol. Please do not give brufen or mefenic acid because that may be associated with more complications. And the dose recommended here is also not 15 mg per kg, just 10 mg per kg, because you are anticipating a hepatic dysfunction as the baby progresses. And always encourage to take electrolyte-rich fluid, Kanyaveda, ORS, milk can be given. Don't allow them to take plain water alone, because most of the children will present to you with hyponatremia. In fact, in our study, we found that 30% had hyponatremia at admission, and hyponatremia will favor the capillary leak. So always better to prescribe an ORS for these children who present to you in the febrile phase. But there are situations where you may require to give an IV fluid. For example, this child had come on the second day. First day, nobody gave an IV fluid. Second day, the child had come. The child was not taking orally. The child was running high fever. So he requires a fluid. So in that situation, what can you do? You can put an NG and can offer an NG fluid. If not, you are starting an IV fluid. Remember, the recommended maintenance fluid rate is just 1.5 ml per kg per hour. Against the routine of 4 ml per kg per hour, you need to give only 1.5 ml per kg per hour, keeping an eye on the urine output. That means you want the urine output more than 1 ml per kg. If you're not getting a urine output of 1 ml per kg, you need to increase the fluid. Always start with only 1.5 and do not use hypertonic fluid. Isolate P is not at all recommended. What is recommended is a maintenance. The DNS is recommended. For resuscitation, you can use normal saline or ringer lactate. So this child, we should have put him on the DNS. So is there any role for investigations? We have been traditionally said that day 1 fever, day 2 fever, don't send investigations. But if when you are in a dengue scenario, you can send an HB and PCV. If you don't want to do a PCV, just send the HB, because hemoglobin into 3 gives you the PCV. You need to know a baseline hemoglobin or a baseline PCV. Only then you would know if the child is going in for a leaky phase, if the child is going in for a dengue hemorrhagic fever. So if possible, if resources permit, in the febrile phase, send for a hemoglobin or PCV to have a baseline idea about it. There is no role for counts at this point. There is no role for platelet count at this point. The only thing that has got a slight role is the hemoglobin. Now coming to another child, 2 children presenting on day 3, both with fever with myalgia. The first child had severe thrombocytopenia, 20,000. So the child was admitted. The second child had relatively normal counts. PCV was 39, not very high. And the platelet was 1.2 lakh. So the child was sent home, only to be brought back the next day morning in shock. So where did we go wrong? Or what do you do when you get a child between 3 to 5 days? That is a time when you are expecting the dengue complications to develop. What are you expected to do? Between day to 3-6, our primary job is to find out is the child having a simple dengue fever or a dengue hemorrhagic fever. Remember, children with dengue fever will have thrombocytopenia but will not have a capillary leak and they do not progress to shock. They may develop an encephalitis, they may develop a myocarditis, or they may develop an acute liver failure. But for them to develop a capillary endotheliopathy and progressing to the classical dengue shock syndrome usually does not happen. And it is the DHF patients who really go in for the multi-organ failure, go in for shock. So you need to find out who is having dengue fever and who is having dengue hemorrhagic fever. How do you find out the dengue hemorrhagic fever? So watch out for warning signs. In fact, all the warning signs indicate that the child has started leaking. Why does an abdominal pain happen? Intense epigastric abdominal pain is a referred pain because of the fluid getting collected in the retroperitoneal space, the perirenal areas. That is why you have intense abdominal pain. It has a positive predictive value of 90% for severe dengue. Similarly, look for ascites, look for pleural effusion. Persistent vomiting. What is persistent vomiting? It is described as 3 episodes of vomiting in an hour or 4 episodes in 6. But any child presenting to you with more than 3 episodes in 24 hours should be taken seriously. And extreme lethargy, restlessness. Why is it happening? Because you're having a brain edema, the capillary leak is happening. The child will be irritable to touch, but otherwise the child will be drowsy and sleeping. The intake will be poor, again indicating you're looking at a dengue hemorrhagic fever. Mucosal bleeds. It may be due to thrombocytopenia, but often it is due to a subclinical DIC, which is contributing to spontaneous mucosal bleeds, especially epistaxis. So look out for those bleeds which is happening. Hepatomegaly more than 2 centimeter. Why is it happening? Because there is a hepatic congestion. There is intrahepatic bleeds may happen. Fatty infiltration may happen, or the pleural effusion is pushing down your liver, again indicating you're dealing with a dengue hemorrhagic fever and naturally progressive increase in hematocrit. So whenever a child presents to you in the critical phase, from our point, in a busy OPD, what do you need to do? Ask them, is the child taking orally? How is the urine output? Do touch the baby. You might not have time to take the blood pressure of every child that you're coming across in a OPD where you're seeing 100 or 200 patients, but you can definitely touch the baby to see how is the capillary filling time, how is the pulse volume, how is the pulse rate. If your dorsalis pedis is well felt, and the extremities are warm, you're probably not dealing, the baby has not yet entered the critical phase. So that much clinically we should be looking for. So now if a child with a warning sign comes, that definitely means that you have to admit the child and closely observe. But a child with thrombocytopenia also needs to be admitted and observed. So how do you know? Post-admission, you really need to confirm that you are dealing with a child with dengue hemorrhagic fever. So how do you confirm that the child is having a capillary leak? You can look at the PCV if you have a baseline PCV, if it is increased by 20%. If you find that the albumin is less than 3.5, if you find your cholesterol is less than 100, if your X-ray is showing a pleural effusion or a point of care ultrasound, that is focus, that is now greatly recommended. Now it is said that whenever a dengue child gets admitted, you need to do a point of care ultrasound and triage them to find out who is having dengue fever and who is having dengue hemorrhagic fever. Those with capillary leak needs a very close monitoring. Those without capillary leak can be monitored less frequently. So what do you really look at the point of care ultrasound is really looking at the gallbladder. As you can see here, the first gallbladder is a honeycomb appearance telling you the severe dengue with severe capillary leak. As the child is improving, you can see how it has changed to striator, to tram track, and finally to a normal gallbladder. So this is one of the things that can be done. The changes in gallbladder happens even before you are developing a pleural effusion. So you can identify a capillary leak also by this. Many times, the patient may present to you with acute abdomen. That is because of the acute acalculous cholecystitis-like situation happening because of the edema of the gallbladder. So that time also we need to think about. So now the child has got admitted and you have a warning sign. So what do? You have to send the hemoglobin and PCV as well as platelet count before rehydration and at 6 ml per kg per hour. Progressively decrease the rate of the fluid provided the vitals are stable and you're having a urine output of 0.5 to 1 ml per kg per hour. If at 6 ml per kg, the baby is not improving, increase the fluid to 10 ml per kg. Now, The rate, what are you trying to do here? You're trying to do is you're trying to match the fluid administration with the rate of feed. So you just want to give enough fluid that produces a urine output of 1 ml per kg per hour. It may not be mandatory for you to catheterize. You can ask the mother to collect the urine in a bottle and for you to see the color of the urine as well as the quantity of the urine. That is mandatory. Now, why are we so much particular looking at the urine output, deciding if the fluid has to increase or fluid has to decrease? You remember in life, life is a boomerang. Whatever you give, you get it back. The same thing happens in dengue. Any amount of extra fluid that you are going to give is going to go to the interstitium, causing a respiratory distress in the critical phase. And if it's not getting back to you in the critical phase, it's going to hit back to you in the convalescent phase when the reabsorption may precipitate a pulmonary edema. So the fluid administration is needed, but it needs to be judicious. Remember, when you're giving a normal saline, even in a normal, healthy endothelial vasculature, only 25% will remain in the intravascular volume, 75% will go to the extravascular compartment. So with capillary endotheliopathy, more will go to the extravascular compartment. So whatever fluid you are giving during the febrile phase, during the critical phase, whatever reaches the interstitial space, it is not going to come back till the baby reaches the convalescent phase. So that we need to remember. Everything is going to get added on to it. That is why I initially said you cannot prevent a baby from going into shock by putting the baby on IV fluid early. Rather, you have to continuously administer fluid, keeping the vasculature open, allowing the body to be perfused with the minimum possible fluid. That is the aim of dengue fluid management. Now, how do you monitor? If a child presents to you with a dengue warning sign, you need to monitor the urine output as well as the vitals hourly. And PCV needs to be sent 4th hourly. If the baby requires more than 3 10 ml per kg, consider it as a severe dengue and it needs to be managed accordingly. And always after a fluid bolus, you need to repeat a PCV. So I hope that is clear. Monitoring is every hourly, PCV is every 4th hourly. Also note, I'm not talking about platelet here at all. We are not bothered about it. If it requires more than 3 10 ml per kg, consider it as severe dengue and manage accordingly. And always after a bolus of 10 ml per kg, you need to repeat the PCV to see if the PCV is still high or the PCV has fallen more than what that is anticipated. And if once the baby is stable, he's off IV fluids, intake is good, urine output is good, you can space out to your monitoring to 4th hourly and you can send your PCV 12 to 24 hours. So depending on the child's condition, you decide the frequency of monitoring as well as the frequency of investigations. Now, which fluid do you want to give? So we already said that usually we prefer crystalloid, but crystalloid has its limitations because only 1/3 remains in the intravascular space and 2/3 goes to the extravascular space. And because the chloride content is high in normal saline, when the child comes to in the critical care management, you may have problem with hyperchloremic metabolic acidosis. In the initial stages, definitely we are not bothered. Crystalloids only you give. So colloid, we said almost 100% remains in the intravascular compartment, but we need to remember that 100% do not remain in the intravascular compartment in dengue. Because in dengue, colloids also leak out. Why is your albumin low in dengue? That is because there is a capillary endotheliopathy. The endothelium is damaged. The albumin has gone to the interstitium. It is not excreted through the urine. The same thing is going to happen with colloid. When you give colloid, that also gets extravasated. That also goes to the interstitial compartment. And on top of that, colloids interfere with cross-matching, interfere with coagulation, can precipitate an acute kidney injury. And colloid in the interstitium is more harmful than crystalloid in the interstitium because colloids can draw fluid from the intravascular compartment to the interstitium. So what does that mean? So it means that, and it has been found that even when you give colloids, you will find there is an improvement in hematocrit, the heart rate, the pulse rate comes down, but it has been found that it does not reduce the recurrence of shock and the total amount of fluid administered or the mortality. So did I confuse you with all this? So what is the consensus regarding fluid? The consensus is regarding, what happened? Movie innilla. So regarding fluids in dengue, we need to know that you have crystalloids are the first choice. Persistent shock after crystalloid, that is after 320 ml per kg of crystalloid. If the child remains in shock, you can think of giving colloid. If the child is shocked and is puffy, you can give colloid after the second bolus. Shock with signs of fluid overload also mandates colloid. Do not use colloids as maintenance. Colloids is given only in a single way, that is 10 ml per kg per hour. And always find a reason to give a blood transfusion. So let us see now. So now coming to the platelet. Now you had seen the child was initially having just a platelet count of 20,000. So do you want to give transfusion to that child? So for that to decide, you need to know why is the platelet low. The platelet is low because initially there is a decreased production of platelet, but subsequently there is no decreased production of platelet. It is because of the antibodies that are being produced against the platelet is getting destroyed. You may have a DIC causing consumptive coagulopathy because of which the platelet is coming down. So in this stage, if you're going to give platelet, that is like adding fuel to the fire. It is not going to benefit you. So there is no role for, does it cause, so there is no role for a prophylactic platelet administration because bleeding in dengue is solely not due to thrombocytopenia. So that is very important. Then what does a low platelet indicate? What does a platelet which is falling in a child indicate? Why do you admit a child with a low platelet? It indicates that the dengue is still progressing. So this child can progress to the critical phase. The child can progress. But dengue, the progress has not been halted when you find that the progressive fall in platelet is happening. So that is why it is taken as a risk factor and admitted. But remember, however low the platelet count is, if the child does not have capillary leak, child is not going to go for a dengue hemorrhagic fever. So what are the indications for platelet transfusion? As I already said, there is no role for prophylactic platelet transfusion. The only indication you give is when the platelet is less than 10,000, because otherwise it precipitates fluid overload, it precipitates thrombosis. You can, and also in massive bleeding. If a child is coming to you and bleeding from everywhere, what do you give first? You want to give the crystalloid, you want to give blood, you want to give platelet, or do you want to give FFP? You need to understand, even when a child is bleeding, the priority is shock correction. You start with crystalloid, give blood as soon as it is available, then give FFP, and still if the baby is continuing to bleed, you give platelet. So the platelet comes lower down even in a child with a bleed, because the bleed is not exactly due to thrombocytopenia. If you want to put a central line, you need a platelet count of 20,000. If it's a patient for a surgical abdomen, you need at least 50,000. Neurosurgical cases would require 1 lakh. But remember, platelet count, even when you have a normal platelet count, there is a platelet function abnormality also in dengue, which also contributes to the bleeding. So now coming to the next case, a 10-year-old child with a seizure disorder who presented on day 3 of fever with cold extremities and abdominal pain. He had petechiae and gum bleed. His BP was 84/70. So the child was correctly diagnosed as having dengue shock syndrome and immediately referred. But the child was from a far off place, so it took around 2 hours for the baby to reach us. By the time the child reached us, the extremities were cold. There was no palpable pulse. BP was unrecordable. Immediately, 2 IV lines were set up. Oxygen was started with non-rebreathing mask. All baseline investigations, including request for grouping and cross matching, was sent. While the bolus was on flow, the child starts bleeding. When I say bleeding, it is not that the child is having epistaxis or a trickling of blood. It is as if a main artery has been uh, cut open. Profuse bleeding from the nose, from the mouth, from the ET tube, pulmonary hemorrhage, and within the next 20 minutes, 3 suction bottles need to be changed because of the massive bleed. Now, why did this child bleed? His hemoglobin was 12. His platelet count was 1 lakh. But his blood gas was showing an ABG of 6.9 with a bicarbonate of 6, with a PTINR of 1.8. So the cause of bleed here was not thrombocytopenia, but the cause of bleed was uncorrected shock. So that we need to remember. Remember, why does a child in dengue bleed? It is because of uncorrected shock, disseminated intravascular coagulation, liver dysfunction, thrombocytopenia, and also release of heparin-like substances from the capillary endothelium. So when you have a child presenting to you in a compensated shock, you need to remember that at that time, your heart is beating, your blood flow is happening, but when you refer without giving a fluid bolus, the capillary leak continues. As the capillary leak continues, the intravascular volume comes down, the endothelium gets more damaged. When the endothelium gets more damaged, it acts as a nidus for thrombus formation, and the microthrombi are going to cause multi-organ dysfunction. On top of it, here the microthrombi will also cause consumptive coagulopathy, because of which all your coagulation factors are being used up, your platelet is being used up, the acidosis is worsening, everything contributes to active bleeding. So that is important to understand the pathophysiology. So whenever you have a child presenting to you in shock, the child needs resuscitation. We need not refer without resuscitation. So having a pulse pressure less than 20, having a BP less than fifth centile, having absent peripheral pulses are all the different ends of the same spectrum of dengue shock syndrome. So the management in all these three scenarios is not the same, even though all of them are in dengue shock syndrome. So what do you do if a child is presenting to you with a hypotensive shock? If the child is presenting to you with a hypotensive shock or absent pulse, start at 20 ml per kg of normal saline. If the child is presenting to you with a narrow pulse pressure, start at 10 ml per kg. If it's warning sign, start at 6 ml per kg. You may need to titrate up or down depending upon your vitals as well as your urine output. So you're always targeting a urine output of at least 1 ml per kg per hour. So now if the child is in shock after the 20 ml per kg of NS, you can repeat a second 20 ml per kg of NS. If the child continues to be in shock even after second 20 ml per kg of NS, send a PCV. If the PCV is high, that means the capillary leak is happening, you go for a third 20 ml per kg of NS. And after the third 20 ml per kg of NS, the child continues to be in shock and the PCV is high, go for colloid. If after 220 ml per kg NS, if you find that your hematocrit is low or hematocrit is normal, any child who's coming to you in a dengue shock syndrome should have a high hematocrit if it is due to capillary leak. If he's having shock and his PCV and hemoglobin is low, we should understand that this is due to a bleed which has happened, which we are not picking up clinically, and the child requires a blood transfusion. And any case of refractory shock, think of ABCD, acidosis. So if you find a child is in shock and his pH is less than 7.3, give bicarbonate. This is the only indication, only shock where you're advising a bicarbonate to be given as a management strategy, because acidosis favors bleeding. So you don't want the bleeding to worsen. That is why you give bicarbonate early if your pH is less than 7.3. Look out for cause, look out for occult bleed, and arrange for blood transfusion as early as possible. Blood transfusions are life-saving. Specifically look for hypocalcemia. Calcium is needed for coagulopathic your cascade as well as for contractility. And always monitor for hypoglycemia. Hypoglycemia as well as hyperglycemia both needs to be managed. So now, when I said all this, I said about the volume of fluid that has to be given. I did not tell how fast you want to give it. So that is the reason is, even when you have done everything according to the WHO protocol, from the periphery to the central to the tertiary, you still lose patients. So there has to be a reason, that something different we have to do to pick up those who die. So what can be done? In fact, we have sent a team of doctors to Singapore by the government of Okay, so this is from the guideline that was shared by them. So we need a fine tuning. So why are we taking lessons from Thailand? The reason is because Thailand has usually more than 1 lakh cases in a year, but the case fatality rate is just 0.09%. And this guideline was prepared by Dr. Siripai, who incidentally is a pediatrician and who was one of the co-authors of the 2009 WHO guidelines. And this center is the WHO Collaboration Center. So what do they recommend? If you have a patient presenting to you in shock with palpable pulses, give fluid at a rate of 10 ml per kg per hour. If you have a child presenting to you in shock with absent pulse, give 20 ml per kg per hour. Once you're giving 20 ml per kg per hour, monitor every 15 minutes. Once the pulse is palpable, decrease the rate to 10 ml per kg per hour. So we already said this, shock with palpable pulse, it is 10 ml per kg per hour. Without palpable pulse, it is 20 ml per kg per hour. And the preferred colloid they prefer is dextran. We have been using hexastarch as the colloid, but they prefer dextran because hexastarch, in fact, is isoosmolar. They say just like Albumin leaks out, hexastat will also leak down. Dextran 40 is hyperosmolar, so that is going to remain in the intravascular compartment for a longer period, and the dose is only 10 ml per kg per hour. So who receives Dextran? Anybody who's presenting to you in shock with respiratory distress, then you go for Dextran 10 ml per kg per hour. If the patient is presenting in shock with severe respiratory distress, you start Dextran at 10 ml per kg per hour. You monitor BP every 15 minutes, and once the BP picks up, a furosemide infusion may be started. So that is an exceptional situation, and that is something that usually you do in an intensive care setting rather than outside in the ward. And remember, once you've given a Dextran, you're expecting the PCV to fall by 10. And if the PCV fall does not happen, you have to again think of an occult bleed. And the most important thing that we need to remember is that the fluid administration should be limited to 24 to 48 hours. The child in shock would have received a lot of fluids. A lot of fluid will be sitting in the interstitium. If you go on giving the fluids beyond 24 to 48 hours, as the child goes into the convalescent phase, the baby will go for a pulmonary edema. So it's very important to judiciously taper and stop the fluid. And so then comes, how do you give the blood transfusion? So if the child is in shock with a normal or a low PCV, go for a whole blood transfusion. If you don't have a whole blood, ask your blood bank to give a reconstituted blood. That is, they will mix your PRC as well as FFP, give it over 10 ml per kg per hour. If the patient is having shock and is having respiratory distress, go for PRC, give it at 5 ml per kg over 1 hour. If the indication while you gave blood transfusion is a worsening metabolic acidosis, decide the rate of administration depending on your urine output. Target a urine output of 1 ml per kg. Every blood product that has been dispatched from the blood bank, a PRC, has to be over within 4 hours. And so when we analyzed the children who died due to severe bleed, what did we find? We found that the median platelet count was 68,000. So that means they were not dying due to massive bleed due to thrombocytopenia. What was common was all these children presented in profound shock, and none of them had received a peripheral IV fluid. But one thing is very heartening, that there were no deaths due to massive bleed in our hospital in 2017, while 22% of children died due to massive bleed in 2013. So that means that the knowledge dissemination after the 2013 outbreak was probably better, leading to better peripheral stabilization. That might have been one of the reasons why the massive bleed had come down in 2017. Another reason could be a serotype replacement. Some serotypes are known to cause more organ dysfunction. Some serotypes are known to cause more capillary endotheliopathy. So we do not know if that has contributed to a decreased incidence of severe bleed. So to summarize, when a patient presents to you in a febrile phase, always encourage oral fluids. If you need to give IV fluids, give DNS at a rate of 1.5 ml per kg per hour. If you want to send an investigation, just send for hemoglobin and PCV so that you know the baseline parameter. When a child comes to you in the critical phase, you need to distinguish between dengue fever and dengue hemorrhagic fever. Specifically look for evidence of capillary leak. Every child with warning sign needs to be admitted. Every child with severe thrombocytopenia needs to be admitted. Once admitted, triage your patients to find out who is having capillary leak and who is not having a capillary leak. Those with a capillary leak should be admitted in a high dependency area and more closely monitored than those without a capillary leak, even if their platelet count is low. Always find a reason to give a blood transfusion and find a reason not to give a platelet transfusion. And in the convalescent phase, taper fluids early, stop them early, try to stop within 24 to 48 hours so that resorption pulmonary edema does not happen. So the final nutshell is that in dengue, the fluid is just like water in nature. If you don't give, if it is less, it leads to drought. If you give too much, it leads to flood. So what you really need is a balance which will help your organs to nurture. Thank you.
Thank you, Sheeja. As always, it was a brilliant talk. So the take-home message is like we should suspect dengue in the periphery. And on day one, when somebody is coming, there is no hurry to do a lot of investigations. And if you are using paracetamol, use it in a lower dose. Encourage the child to take more oral fluids and plain water is not what we need. We can ask them to take ORS or Kanji water. And also don't look at the platelet count. You have to look for the signs of capillary leak. That is the most important thing, because most children die later because of profound shock, which causes the massive bleed rather than thrombocytopenia. And giving platelets are not very helpful always. Rather than that, you have to prevent shock from happening. So I will ask a few questions which were given. Before that, one question to Sheeja. We all, when we were practicing this, our what do you call that? That paracetamol dose. Regarding that paracetamol dose, is 10 milligram enough, for 15 milligram is needed? Because in the initial days, fever will be a very important symptom.
Yes, fever is an important symptom, but still the recommended dose is 10 mg per kg only.
Okay.
That
Okay.
is
So
better. 15 പോയിന്ന് വെച്ച് ഒത്തിരി ഒന്നും അപ്പം സംഭവിക്കാൻ പോകുന്നില്ല. കാരണം ഫെബ്രൈൽ ഫേസിലാണ് ഈ സമയത്ത് എല്ലായിടവും നമ്മുടെ പെർഫ്യൂഷൻ നടക്കുന്നുണ്ട്. ഹെപ്പാറ്റിക് പെർഫ്യൂഷൻ കുറയുന്ന സമയത്ത് പാരസെറ്റമോൾ ഡോസ് കൂടുന്നതാണ് കൂടുതൽ ഹാർംഫുൾ. So whatever dose you start, the same dose will be continued in the critical phase also. So that is the reason why they are telling that give it at 10 mg per kg. Because in the critical phase, you definitely want it. And remember that നമ്മൾ പഠിച്ചിട്ടുള്ളത് critical phase fever മാറുമ്പോഴാണ്. അങ്ങനല്ല. Critical phase can start with the fever still there. So never expect that a child will go into critical phase only a febrile phase. Febrile phase can also go into the critical phase.
and
അത്
there was
കാരണമാണ് paracetamol dose ceiling അങ്ങനെ 10 mg per kg എന്ന് പറയാൻ കാര്യം.
one related question, which antipyretic other than paracetamol, if there is an allergy or something like that?
That becomes a very tricky question, because the next usually if AAP recommendation, next antipyretic is Brufen. But in this case, definitely Brufen is not recommended because of the antiplatelet activity. These drugs may have the gastritis incidence that may be on the higher side. But it's always better to go for paracetamol as well as tepid sponging.
Tepid sponging, right. So that will be
better. അങ്ങനെ ഇല്ല എങ്കിൽ പിന്നെ അല്ലെങ്കിൽ പിന്നെ using a sucralfate along with a Brufen or something. But still, I wouldn't recommend that. Prefer to go for a paracetamol itself.
Okay. And one question about the bradycardia. Is bradycardia always a sign of myocarditis, or can there be bradycardia without being alarming sign?
Basically, what we need to know is that നമ്മൾ എപ്പോഴും പറയും ഡെങ്കിയിൽ ഷോക്കിൽ ടാക്കിക്കാർഡിയ വരില്ല. അങ്ങനില്ല. In fact, the early stages when the patient goes in for dengue shock, they do have tachycardia. The bradycardia you usually see in the recovery phase ലാണ് usually you're going to see bradycardia. But in fact, that's a good sign. നമ്മുടെ ഹാർട്ട് റേറ്റ് കുറയുമ്പം അപ്പൊ ഇവൻ 2-3 ദിവസമായിട്ട് പനി ഉണ്ട് ഇരുന്ന ഒരു കുട്ടിയാണെങ്കിൽ അവന്റെ ഹാർട്ട് റേറ്റ് കുറഞ്ഞെങ്കിൽ അതിന്റെ അർത്ഥം the interstitial fluid has gone into the intravascular fluid. Even if he has not developed a polyuria, he's going to develop a polyuria in the next 1 or 2 or a couple of hours. So usually it is a good sign. Regarding myocarditis commonly presents with tachycardia rather than bradycardia. But in dengue, we do come across conduction abnormalities and bradycardia also. And there a trop I may be more beneficial. But again, myocarditis ne kurichu parayanullathu oru otta criteria veche dengue myocarditis diagnose cheyan pattilla. Even when you have a normal trop I, when you do an echo, you will find the contractility is poor. Or you can have an abnormal trop I with a perfectly normal contractility. You will have everything normal, but your ECG is abnormal, child going in for a VT or a conduction abnormality can also happen. Because pathophysiology paladana. Dengue virus can go to the conduction pathway and block it. Dengue can cause increasing the PCV, decrease the blood flow, causing an ischemic damage to the kidney, to the myocardium. That is when you get a trop I or trop T elevated. Multi-pathology, you cannot say like that. എങ്ങനെ വേണേലും dengue myocarditis manifest ചെയ്യാം.
And one question regarding, is there any cutoff for a platelet count for admission?
അത് ശരിക്കും പറഞ്ഞാൽ ഇൻസ്റ്റിറ്റ്യൂഷണൽ കട്ട് ഓഫ് ആണ്. നമ്മളിപ്പം നമ്മൾ SAT കഴിഞ്ഞ വർഷം അതിന് മുമ്പത്തെ വർഷം what we did was every baby with less than 1 lakh we used to admit. And അതിനകത്ത് നല്ലൊരു number did not have any problem. അപ്പോൾ that is why I stress that less than 1 lakh it is okay to admit. But പിന്നെ അവന് രണ്ടാമത് ട്രയേജ് ചെയ്യുക. അതിനകത്ത് ആർക്കാണ് കാപ്പിലറി ലീക്ക്, ആർക്കാണ് കാപ്പിലറി ലീക്ക് ഇല്ലാത്തത്. കാപ്പിലറി ലീക്ക് ഉള്ളവരെ ഒരു സെപ്പറേറ്റ് വാർഡിൽ കിടത്തിയാൽ നമുക്ക് കുറച്ചുകൂടെ ക്ലോസ്ലി ആ വാർഡിൽ കിടക്കുന്നവരെ മോണിറ്റർ ചെയ്യാം. ദാറ്റ് ഇസ് എ ഗുഡ് സ്ട്രാറ്റജി. If you are expecting a large outbreak, it would be better to do like that.
Okay. And I think we will close because of the time problem. But one important question is there. What are the criteria for referral from a peripheral center? Till what stage we can manage? There is one question. That.
Okay. Criteria for reference. If, for example, febrile phase, if it depends upon where we are working, അല്ലേ, നമുക്ക് അവിടെ കിടത്തി കുറച്ചെങ്കിലും ഫ്ലൂയിഡ് കൊടുക്കാൻ പറ്റുന്ന ഹോസ്പിറ്റലാണോ, അതല്ല നമ്മളൊരു പെരിഫറൽ സെറ്റപ്പിൽ നമുക്ക് IP ഇല്ലാത്ത സെറ്റിംഗ് ആണ്. IP ഇല്ലാത്ത സെറ്റിംഗ് ആണെങ്കിൽ the most important thing is how is the child's appetite and how is the child's urine output. That is in the febrile phase. Appetite, naturally every child in viral fever is going to have a poor appetite. അമ്മയുടെ പാല് കുടിക്കുന്നുണ്ട്, യൂറിൻ ഔട്ട്പുട്ട് ആവശ്യത്തിനുണ്ട്, ധൈര്യമായിട്ട് സപ്പോർട്ടീവ് കെയർ കൊടുക്കുക. ആൻഡ് ടെൽ ദം യൂറിൻ ഔട്ട്പുട്ട് കുറയുവാണെങ്കിൽ കൊണ്ടുവരണം. ഫെബ്രൈൽ ഫേസിൽ ഡിക്രീസ് യൂറിൻ ഔട്ട്പുട്ട് വുഡ് ബി ആൻ ഇൻഡിക്കേഷൻ ടു റെഫർ. ക്രിട്ടിക്കൽ ഫേസിൽ എനി ചൈൽഡ് വിത്ത് എ വാർണിംഗ് സൈൻസ് യു നീഡ് ടു റെഫർ. Any child who is vitals are abnormal, that means when you are touching the periphery is cold, the intake is poor, the child is extremely lethargic, ഏത് warning sign വന്നാലും we need to refer. Urine output കുറവാണെങ്കിൽ orally കൊടുക്കാൻ പറ്റുന്നുണ്ടെങ്കിൽ you don't have to refer. Orally കൊടുക്കാൻ പറ്റുന്നില്ലെങ്കിൽ you need to refer. ഇനി സെക്കൻഡറി ലെവൽ എന്ന് വെച്ചാൽ നമുക്ക് അഡ്മിറ്റ് ചെയ്ത് മോണിറ്റർ ചെയ്യാൻ പറ്റും, പക്ഷെ നമുക്ക് അവർലി ഒന്നും മോണിറ്റർ ചെയ്യാൻ പറ്റത്തില്ല. അങ്ങനത്തെ ഒരു സ്ഥലമാണെങ്കിൽ ത്രോംബോസൈറ്റോപീനിയ ഉള്ള കുട്ടികളെല്ലാം നമുക്ക് അഡ്മിറ്റ് ചെയ്യാം, കുഴപ്പമില്ല. അവർക്ക് ഒരു എവിഡൻസ് ഓഫ് കാപ്പിലറി ലീക്ക് ഉണ്ട്, ചെറിയ പ്ലൂറൽ എഫ്യൂഷൻ ഉണ്ട്, അങ്ങനത്തെ കാര്യങ്ങളുണ്ട്. എന്നാലും അവരുടെ യൂറിൻ ഔട്ട്പുട്ട് ആഡിക്വേറ്റ് ഉണ്ട്, ഫ്ലൂയിഡ്സ് വരുന്നുണ്ടെങ്കിലും we can still manage the child there because you need to monitor them 3 to 4 hours. But if a child has a characteristic warning sign, that means the child is having respiratory distress വരുന്നു, അല്ലെങ്കിൽ the child is having intense abdominal pain or the child is having recurrent vomiting, it is better to refer because you need to monitor the child hourly. അപ്പോൾ വാർണിംഗ് സൈൻസ്, ടിപ്പിക്കൽ വാർണിംഗ് സൈൻസ് ആണെങ്കിൽ അവർലി മോണിറ്റർ ചെയ്യാനുള്ള ഫെസിലിറ്റി ഇല്ലെങ്കിൽ you will need to refer. And severe dengue, naturally massive capillary leak, severe respiratory distress, anybody with shock. ഇപ്പോൾ ഒരു കുട്ടി ഒരു ഷോക്കിൽ വന്നു, ഒരു ഫ്ലൂയിഡ് കൊടുത്തപ്പോൾ അവൻ ശരിയായെങ്കിലും this is a child who's going to again go into shock. So if in your facility you can monitor the child frequently, you retain the child. If in your facility you cannot monitor the child frequently, then we need to refer the child.
Thank you, Sheeja. Now we will take a break from academics for a few minutes. Over to Bennett sir for the release of the newsletter proceedings.
Thank you, Riaz. It is a great pleasure that we are going to release this newsletter starting from this month. And our National Executive Board member, Dr. Kunju sir, agreed for the release of this magazine. I request Kunju sir to come forward and say a few words and release the magazine. Kunju sir.
Okay, so good evening, everybody. Respected President of Trivandrum, Dr. Bennett, and our State President, Dr. Narayan, State Secretary, Dr. Balajandar, Trivandrum Secretary, Dr. Priya, Dr. Riaz, and all my brothers and sisters in IAP. I am happy that again today also Trivandrum IAP is rocking with IAP trivandrum.org, the newsletter, launching of a newsletter of this year, because Trivandrum IAP.org was the publication which was being done earlier itself. And again, I am happy that with the enthusiasm of our President, Dr. Bennett, and that of Priya, we are having a lot of activities, and the rainbow was very much appreciated even by our national IAP members. So I think this also is a very good activity. And all these things, that means the newsletter, because you may think that it may not be that much important thing. The activities are more important, but many, because the T-shirt Ike or T-shirt, the entrepreneur, he was telling that never underestimate the power of a T-shirt, because you may host a perfect event, but if your T-shirt is not in the proper mode, everybody will be speaking about that only. So that means here also, if you are not showcasing your activities in a good manner, whatever we do, it may not be remembered at all. Because even now I am keeping the first the edition of our companion. I just gave Dr. Jason the first copy of the companion. Similarly, that means we are all, at least some people will be keeping all these things. And after years, people will remember that Dr. Bennett and Priya, with the help of our young docs, Dr. Amit and Prashant, has done a wonderful job. And so that means this is for posterity. So I think I'm happy to release the, I think Amit or Prashant will be showing it. I am officially releasing it. Hope Prashant and Amit are there, and they'll be releasing the digital version.
Thank you, sir.
Okay, Bennett. Hello?
Thank you very much. Thank you very much, sir.
Yes, yes.
Riaz? Okay, Amit.
Yes. Amit is doing the act.
No.
Share ആയിട്ടുണ്ട്.
Yes, yes, excellent cover. Again, just rapidly go through that pages so that all can, all our participants can see it. Rapidly flip through. I'm happy that our state president and secretary is able to witness all these activities of their branches. They were the Calicut activity also.
ഇച്ചിരി enlarge ചെയ്തെങ്കിൽ കൊള്ളായിരുന്നു കേട്ടോ.
ഇത് കാണാം സർ.
ഫുൾ സ്ക്രീൻ. ഇത് പറ്റി.
കാണാം.
ഓക്കേ ഓക്കേ.
That's all, sir.
Okay. Okay, thank you, Bennett, for inviting me to release the newsletter. Thank you.
Thank you, sir. Thank you, sir. Because of your motivation only, we could make all these things, magazine and newsletter. Thank you, sir. Over to Riaz. Thank you.
So the next talk in the session is by Dr. Anju Deepak on another infection which we are all anticipating, that is leptospirosis. Especially with the last year and the year before last, when we had floods, there was an increase in number of leptospirosis. Usually we get less number of cases in children, but with the flood situation and all, we should be expecting more, and we should be ready to manage. Over to Anju.
All, I would like to thank IAP Trivandrum and the Secretary Priya and Bennett sir for giving me this opportunity. I would like to congratulate Sheeja on her excellent talk. It is quite intimidating for me to speak after such an excellent speaker, but I'll try to do my best. Leptospirosis pose mostly, it's a diagnostic dilemma, and I would be giving an overview of leptospirosis. Now I'll share the screen. So leptospirosis, as we all know, is a disease that is common in the monsoon season. The names given to leptospirosis like Weil's disease, waterborne fever, rice field fever, swarm fever, etc. It's a most widespread zoonosis in the world caused by an organism called Leptospira. The incidence is 10 times more in the tropics compared to the temperate regions. It is an underreported disease as there are no reliable global incidence figures. According to WHO, 873,000 cases are recorded annually worldwide with 48,600 deaths. In India, mainly it's reported in South and Southwest India. After the floods in 2002 and 2005, Mumbai had a lot of cases. It has become prevalent in Kerala also during the monsoons. Around 1,000 cases and 100 deaths were reported till 2010. As of September 11, 2018, 2,598 cases were suspected, of which 1,318 were confirmed. And there was a mortality rate of 4% recorded. The hosts are various mammals. Incidental infection to humans is by contact with either the animal or the environmental exposure. Both wild and domestic animals are affected. It's very common in rodents, cattle, goats, and dogs, but rarely seen in cats. The most common reservoir that we come across are rodents who shed the organism through the entire lifetime, contaminating water and soil. Human infection is through direct or indirect exposure to infected water, soil, with animal urine or animal tissue. The portal of entry, as we all know, are through cuts, abraded skin, mucous membrane, and conjunctiva. It is rarely by the injection of food contaminated with urine or via aerosols when it is inhaled, when the contaminated water is inhaled in. There is an occupational risk of exposure for farmers, sewage workers, veterinarians, and military personnel, and also people who love to swim, canoe, and kayak also have it as a recreational risk. Increased rainfall and flooding does increase the incidence of the disease as people tend to wade in stagnant water. Poor living conditions with poor hygiene is also another cause. Direct transmission from human to humans is rare. There are 250 seroids of this pathogenic Leptospira, which is grouped into 24 serogroups. Mainly in India, we come across 9 pathogenic types. Leptospira are spiral-shaped, highly motile aerobic spirochetes with 18 or more coils per cell. It is best visualized under dark microscopy. It is differentiated by the characteristic question mark hook at the end of the bacterium. And the Leptospira can grow in blood, urine, and CSF. Incubation period is 2 to 26 days with an average of 10 days. It can either be a mild subclinical anicteric disease or a severe icteric disease with syndrome of multi-organ dysfunction, which can be fatal. But it is less commonly found in children. The common features of the anicteric disease are fever, rigor, headache, and myalgia. A frequently overlooked sign is the conjunctival suffusion, which is seen in 55% of the patients. This symptom is not common in other infectious diseases, which lead us to suspect Leptospira. Non-productive cough can also be seen in 25 to 35% of cases. About 50% of cases present with nausea, vomiting, and diarrhea, confusing it with salmonella. Muscle tenderness, lymphadenopathy, hepatosplenomegaly, and respiratory symptoms are also noted. About 10% of the children present with rashes. It can be of any type like erythematous, maculopapular, petechial, urticarial, or purpuric. 80% of the children have abnormal CSF profile, but only 50% with clinical meningeal manifestations. Polycirrhosis, if seen, is in the form of pleural fluid, pericardial fluid, ascites, and gallbladder wall edema. Icteric form may mimic viral hepatitis, but without polycirrhosis and cholecystitis. This disease is a biphasic illness where the first phase is acute febrile bacteremic phase for the first 2 to 9 days. It is during this time that leptospirosis are detectable in blood. The second phase is the immune phase. It may prolong from weeks to a month, where there is a renewed episode of fever and the development of complications. During this phase, leptospirosis are not seen in blood but can be obtained in urine. In certain settings, of severe disease, these two phases may overlap also. Diagnosis is mainly by serology. Leptospirosis can be cultured from blood and urine, but it may take weeks. Microscopic agglutination test is the gold standard, where blood samples have to be taken at least 2 weeks apart and studied in the same laboratory. Both culture and mat sensitivity are only 55.5% with a specificity of 98.8%. Commonly, what we do is the IgM ELISA, which comes positive on the 5th day of illness with 90% sensitivity. Real-time PCR can also be done, and the DNA can be found in blood during the initial bacteremic phase, and later it can be obtained from urine and CSF. The antibodies, and when ELISA and PCR comes positive, we can send the blood for MAT, which is a confirmative test, as well as it can be used for epidemiological purposes. The antibodies appear 5 to 7 days with a sensitivity up to 84% and a specificity of 92%, and a single titer of more than 1 in 800 is a reasonable evidence of current infection. A titer of 1 in 200 will give us the endemicity of the disease. MAT is a live antigen suspension of leptospiral serovars under dark field microscopy for agglutination, and the titers are determined. A fourfold increase in titer in a paired sera is considered confirmative. Agglutinins usually appear by 12 days and reach maximum by the 3rd week. Though this is the gold standard, it has a lot of limitations as it is available only in select research institutes. The antibody titers rise and peak only in the 2nd and the 3rd week, making it less sensitive. High titers of past infection persist for a long time and interfere with the present diagnosis. The second sample is usually required to confirm, depending on the endemic or non-endemic area. Test is complicated, requiring dark field microscopy and cultures of live serovars. There are other available tests which has a sensitivity of up to 85%, which has been used all over India for diagnosis, like the slide agglutination method, dry dot assay, leptodipstick, latex agglutination, complement fixation assay, indirect immunofluorescent test, and indirect hemagglutination. We can also see certain characteristics in the other common laboratory investigations we send. As in CBC, you can find neutrophilia with polymorphonuclear predominance. Platelets are usually low. Peripheral smear can show toxic granules in neutrophils. CRP is positive. Serum albumin may be low. Around 50% shows elevated CK. Hepatic transaminases and bilirubin are also elevated. Hyponatremia and hypokalemia is noted. In urine, you can have proteinuria, pyuria, or occasional hematuria. CSF shows lymphocytic or neutrophilic pleocytosis, an increase in protein, and normal glucose. Chest X-ray can be either nodular densities or consolidation can be seen with ground glass appearance when there is pulmonary involvement. Certain findings like oliguria, neutrophilia, repolarization abnormalities in ECG, and alveoli infiltrates on chest X-ray point towards adverse outcomes. We can also use certain clinical criteria for suspecting leptospirosis. The Indian Leptospirosis Society's criteria says that any child with abrupt onset high fever, more than 39 degrees C, with body ache and headache, or with one or more features, following features can be considered as a strong suspicion for leptospira, like jaundice, oliguria, cough and breathlessness, hemorrhagic tendency, or signs of meningeal irritation or altered sensorium. The modified Fain's criteria, which is used in adults, can also be used in diagnosis of older children and adolescents. A score above 25 is considered positive. Now, when IgM comes positive for dengue and leptospirosis, which we commonly see as both the tests are sent together in a clinical scenario where we cannot get a clear picture, it is found that there is a cross-reactivity for dengue and leptospira antibodies in blood, and the IgM antibodies formed when the patient suffers from one of the two infections may remain in blood for a long time. Another possibility is that the reagents used could be of having poor specificity. The rapid tests of dengue are also having limited sensitivity and specificity, and hence they produce false positive results in patients with leptospirosis. Hence, it is crucial that the diagnosis is not excluded early, so that patients tend to enter this severe phase when we start treatment. Leptospirosis has to be differentiated from malaria, dengue, chikungunya, scrub typhus. It may rarely mimic salmonella. It can also coexist together with malaria, dengue, scrub typhus, and viral hepatitis. So it would be wise to investigate for all these diseases too, even if the patient is confirmed for leptospirosis. Complications, though rare in children, are also seen. Around 50 to 85% of patients in CSF, aseptic meningitis is found after the 7th day of illness, but it recovers after recovery. It recovers without any sequelae. Jaundice and renal failure are also seen. Though renal failure is not a common finding, it is the most common risk of mortality in children. Pulmonary hemorrhage and ARDS can also come. Optic neuritis and uveitis have also been reported. Myocarditis, though rare, is also found with a clinical picture of short febrile illness, disproportionate tachycardia, muffled heart sounds, and cardiomegaly with or without a raised CKMB. The outcome is very poor if myocarditis sets in. Rhabdomyolysis is commonly seen. Renal failure, which is found, is often non-oliguric associated with hypokalemia. This is where the supportive renal therapy has to be initiated in the acute phase itself to reduce the mortality of these children. Mostly it is interstitial nephritis and acute tubular necrosis what is seen. Early antibiotics and dialysis have been shown to help in the reduction of mortality. Liver failure is generally reversible. ARF and jaundice are less common in children than in adults. Vasculitis with necrosis are also reported in severe cases. The overall mortality in Kerala is around 4 to 15%. Very rarely, late sequelae can be seen, though it is more prevalent in adults. Patients may suffer from chronic fatigue and headache for a few months. Paresis and paralysis are noted in adults. Mood swings and depression are noted both in children and adults. A few cases of uveitis and iridocyclitis have been reported, with even complete blindness after recovery. Very few studies have been done in India for the past few years. There has been certain studies done after the floods in Mumbai slums and city, where it was found out that the infection is less prevalent in children compared to adults, and only 30 to 40% of the children needed hospital admission with a mortality rate of 8%. Also, the efficacy of tests like rapid tests like dry dot test and ELISA was done, which was found to be equally effective. A study done in early 2000s in Children's Hospital also showed that endemicity of a disease can be concluded by the MAT and DFM values, which came quite high, highly positive, showing Tamil Nadu to be also a endemic area for leptospirosis. In Kerala, not much studies have been done in the recent years, but in 2018, from January to July, 28 deaths were reported due to leptospirosis. After the floods in September 2018, there were 500 deaths, of which, according to the Integrated Disease Surveillance Project, 4% was attributed to leptospirosis, and by the Kerala State Health Department, 2% was attributed to leptospirosis. The maximum death was recorded in Kozhikode district. Until 2018, mortality rates varied from 7.4% to 16%. Now, coming to the treatment part, all uncomplicated cases can be treated with oral amoxicillin, 50 to 100 mg per kg per day for 7 days. And people sensitive to penicillin can be treated with amoxicillin, 10 mg per kg per day for 3 days. Doxycycline can be given for children more than 7 years at a dose of 5 to 10 mg per kg per day for 7 days. Cefixime has also been proved to be effective from 10 mg per kg per day to 15 mg per kg per day for 7 days. For hospitalized children, the gold standard still remains IV penicillin, 50,000 to 1 lakh units per kg per day in divided doses of 4 to 6 times a day. Ceftriaxone and cefotaxime has also been found to be helpful with the same efficacy as that of penicillin. In certain patients where leptospira is confused with rickettsial infections, it is said that it is better to use doxycycline, as penicillin and cephalosporins are less sensitive to rickettsial infections. Azithromycin has also been tried as IV, 10 mg per kg on day 1 with a maximum dose of 500 mg, followed by 5 mg per kg per day for 6 days. During antibiotic therapy, a Jarisch-Herxheimer reaction has also been found quite commonly in adults. This occurs due to the acute inflammatory response to the clearance of the spirochetes from the circulation, which is characterized by fever, rigor, and hypotension, to which we have to pay attention while treating with antimicrobials. Together with the antimicrobials, supportive care plays a huge role in treatment of leptospirosis. The fluid and the electrolyte balance have to be maintained. Due to hyponatremia, the patient can develop complications. Hence, sodium-containing solutions have to be given if the patient is severely sick. Cardiovascular collapse has to be treated, and there should be a provision for dialysis treating severe cases of children to prevent renal failure, as that is one of the most important reasons of mortality. Inotropes have to be given for hypertension, which is refractory to fluid therapy. Rarely, IV corticosteroids have been given where there is a pulmonary involvement, but there is insufficient data for its routine use. Together with supportive care, frequent monitoring of the vital parameters have to be there. Hemodynamic assessment has to be done, and careful charting of intake and output has to be recorded. A few vaccines have been developed which were all serovar specific in different parts of the world for specific epidemiological circumstances. None is widely available, and hence its efficacy is also bad. The best things that we can teach our children is to avoid playing and wading in puddles and stagnant water. Rodent control has to be done before every monsoon season. Protection of food from animal contamination has to be there. Immunization of livestock and family pets have found to reduce the disease burden in endemic countries. And creating an awareness on environmental hygiene, like any other disease, helps in this infection too. Though prophylaxis has not been mentioned for children, for adults, there has the doxycycline is found to be quite effective as prophylaxis in pre and post exposure. In pre-exposure, doxycycline 200 mg orally is recommended every week for 2 to 3 weeks till the end of exposure. And for pregnant women and those allergic to doxycycline, azithromycin 500 mg can be given stat and weekly till the end of exposure. For those people who are residing in endemic areas where there is an outbreak of leptospirosis, when they develop the first symptoms of fever and tiredness, as a post-exposure prophylaxis, they can be given doxycycline 200 mg stat followed by 100 mg BD for 5 to 7 days from the first onset. Azithromycin can also be given as prophylaxis. Now, to conclude, the diagnosis is difficult due to varied presentations. Non-icteric leptospirosis symptoms are non-specific, and hence high index of suspicion is needed for diagnosis. In the first week, clinical criteria has to be used for early diagnosis. And starting an empirical therapy as soon as the clinical diagnosis is made reduces the mortality to a great degree. Rapid tests are equally effective, but can be done only in the second week. Commonly confused with dengue as they commonly overlap in monsoon. And causes of death, as discussed, are most commonly due to renal failure in children, but early dialysis can reduce the mortality. Cardiopulmonary failure and widespread hemorrhage is also seen. Though jaundice is present in children with liver involvement, liver failure is rare. Thank you.
Thank you, Anju, for a vivid, clear presentation. All aspects of leptospirosis is covered. And now there are a few questions. We will go to the questions. One is regarding doxy treatment, any age cutoff? Hello.
Actually, doxycycline is not recommended in any pediatric age. What they have recommended is for the adults, but they say that half the dose of the adults can be also used in children. And even they say that doxycycline prophylaxis is, if given up to 21 days in children, have found to be not causing any complications.
Okay.
Adult dose can be used.
Actually, this question arose when this flood occurred in 2018, and at that time, I think the state had decided to give for those above 7 years.
Yeah, that is what it is written, above 7 years, and azithromycin can be given for smaller children.
Correct.
I think somebody
correct.
can, if they know, can.
Correct. I think Bala, Bala, do you want to add something, because from the health service guidelines?
About two things, what Anju said. One is the dose of penicillin. I think it should be 50,000 units per kg per dose for 4 times.
Yes, sir.
Yes.
And the other one is that one pre-exposure. Doxy has to be continued till one is exposed.
Yes, sir.
And not to, you have written 2 to 3 weeks until at the end of the exposure, like that.
Okay, sir.
Usually, it is because usually when we go to a endemic place, it will be for a short stay, like 2 weeks or so. But during the last flood situation, we were forced to continue it for more time because they were residing in the same situation for a longer period. So that is something we learned through the flood. Then, any more questions? I think it is.
Presentation, Anju has covered all the points.
Yes,
Somebody
yes.
has asked about tetracycline, but when I read the literature, it is said that doxycycline gives very good effect, so that tetracycline can be avoided in children.
റിയാസെ
ഹലോ
നമ്മുടെ സുലേഖ മാഡത്തിനെ ഞാൻ അൺമ്യൂട്ട് ചെയ്തു. മാഡം റേസ് ഹാൻഡ് ചെയ്തിട്ടുണ്ടായിരുന്നു.
മാഡം സുലേഖ മാഡം കേൾക്കാമോ?
അൺമ്യൂട്ട് ആയിട്ടില്ല പ്രിയ, സ്റ്റിൽ മ്യൂട്ട് ആണ്.
ഞാൻ ഒന്നും കൂടെ ചെയ്യാം.
മാഡം ഒരു കമന്റ് ഡെങ്കി ലെപ്റ്റോ ഒക്കെ മാഡം we would like to hear from you.
പക്ഷേ അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റുന്നില്ല.
ആയോ?
പറ്റുന്നില്ല.
ഇപ്പൊ ആയി. മാഡം തന്നെ അൺമ്യൂട്ട് ചെയ്യണം തോന്നുന്നു.
ആയിട്ടുണ്ടോ?
ഇപ്പൊ ആയി.
Regarding anyway, congrats to both the speakers. Very good presentation, and really you have touched upon the most important things in the two illnesses. I would like to ask Sheeja, when you give 20 ml per kg in dengue shock, you mentioned, but I couldn't hear. How quickly should you give each bolus? I think it is 10 to 15 minutes. Am I right?
ഷീജ അൺമ്യൂട്ട് ചെയ്യണം.
ഷീജ അൺമ്യൂട്ട് ചെയ്തിട്ടില്ല.
അപ്പം വാട്ട് ഐ വാസ് ടെല്ലിംഗ് ഇസ്, നമ്മൾ മാഡം നേരത്തെ അങ്ങനെ പഠിപ്പിച്ചുകൊണ്ടിരുന്നത്, ദാറ്റ് ഇസ് ഡെങ്കി ഷോക്കിൽ വന്നാൽ പ്രത്യേകിച്ചും ആബ്സെന്റ് പൾസ് ആണെങ്കിൽ the first bolus of 20 ml per kg is given over 15 minutes, the second bolus is given over 30 minutes, and the third bolus over 1 hour. അങ്ങനെയായിരുന്നു ഓൾഡ് ടീച്ചിങ്. പക്ഷെ ഇപ്പൊ പറയുന്നത് അത്രയും റാപ്പിഡ് ആയിട്ട് നമ്മൾ കൊടുക്കുമ്പം കാപ്പിലറി എൻഡോഥീലിയൽ ഷിയർ പ്രഷർ കൂടിയിട്ട് ഹെമറേജിലോട്ട് പോകാനുള്ള ചാൻസ് കൂടുതലാണ്. ആ സാധനം ബ്ലീഡ് ചെയ്യാൻ മാത്രമല്ല ഇൻഡസ്ട്രീഷ്യത്തിലോട്ട് പോകാനുള്ള ചാൻസും കൂടുതലാണ്. അപ്പം ഇപ്പം കേരള ഗവൺമെന്റ് പ്രിഫർ ചെയ്യുന്നത് നമ്മൾ തായ്ലൻഡിന്റെ പ്രോട്ടോകോൾ ഫോളോ ചെയ്യാനാണ്. അതനുസരിച്ചിട്ടാണെങ്കിൽ if the patient comes in shock with absent pulse, it is 20 ml per kg over 1 hour. And if the patient is presenting to you with pulse with hypotension, the rate is 10 ml per kg over 1 hour. കാരണം സെപ്റ്റിക് ഷോക്ക് പോലെ ഇത് പെട്ടെന്ന് തീരാൻ പോകുന്നില്ല. ഈ ഷോക്ക് അടുത്ത 48 hours കാണും. അപ്പൊ ആ സമയം വരെ നമുക്ക് പിടിച്ചു നിൽക്കണം. റെസ്പിറേറ്ററി ഡിസ്ട്രസ്സും മറ്റു ഓർഗനിൽ ഇൻഡസ്ട്രീഷ്യൽ എഡീമ വരാതെ പിടിച്ചു നിൽക്കണമെങ്കിൽ കഴിയുന്നത്രയും കുറച്ച് ഫ്ലൂയിഡ് കൊടുത്ത് മുമ്പോട്ട് കൊണ്ടുപോവുക. ആ ഒരു കൺസെപ്റ്റിലാണെന്ന് തോന്നുന്നു അവരങ്ങനെ പറഞ്ഞിരിക്കുന്നത്. മാഡം
Okay, very clear. Thank you. I just want to ask the SAT people. Can you hear me?
Yes, madam. Yes.
In lepto, are you still admitted cases? Are you continuing to use crystalline penicillin as a first drug of choice?
Yes.
Many hospitals are not having crystalline penicillin. That is a very sad part.
Yes, in the private sector, we are using ceftriaxone.
ഞങ്ങളുടെ ഹോസ്പിറ്റൽ സെറ്റപ്പിലുണ്ട്, ഹെൽത്ത് സർവീസിലും ഉണ്ട്. ഞങ്ങളും CP കൊടുക്കുന്നത്.
Sir, but private setup il kittunnilla sir CP. We are not getting it, so we use ceftriaxone.
Okay. So that's all. Thank you.
Okay, madam. Thank you very much for joining and sharing your experience. Actually, now it is we are past by 30 minutes above the schedule, but the conference is full actually. There are around 90 participants still now. And we would like to conclude the meeting by comments from Dr. Narayan is there, our state president.
ഷീജ മേഡം ഒരു ചോദ്യം ചോദിച്ചോട്ടെ?
ചോദിക്കൂ.
ഞാൻ കുറച്ച് കേട്ടില്ല. അപ്പൊ ഈ നമ്മളിപ്പോ ഫീവർ ത്രോംബോസൈറ്റോപെനിയായിട്ട് വരുമ്പോൾ ഡെങ്കി പോസിറ്റീവ് കോവിഡ് ടെസ്റ്റ് ചെയ്യേണ്ട ആവശ്യമുണ്ടോ? എല്ലാം കോവിഡ്
ആസ് ഓഫ് നൗ നമ്മൾ ഇപ്പോഴും ഫോളോ ചെയ്യുന്ന പ്രോട്ടോകോള് റെസ്പിറേറ്ററി സിംറ്റംസ് ബാർ മറ്റേ സിംറ്റംസ് ഹോട്ട്സ്പോട്ടിൽ നിന്ന് വരിക, കോൺടാക്ട് വരിക, അങ്ങനെയാണെങ്കിൽ മാത്രം നോക്കിയാൽ മതി എന്നുള്ളതാണ്. അപ്പൊ ഒരു കോൺടാക്ട് അത് ഇപ്പോഴും ടെസ്റ്റിംഗ് ഗൈഡ് ലൈൻ മാറിയിട്ടില്ലല്ലോ. അപ്പം അങ്ങനെ വരുവാണെങ്കിൽ നോക്കേണ്ടി വരും, അല്ലെങ്കിൽ വേണ്ട.
Hello, Sheeja.
Madam.
Can you hear me?
Madam.
One, I want clinically, when you see a patient, the coldness of the extremity. And also you can clinically look for, your reddened nails, palms, in your eyes, These give you an indication clinically without any laboratory help to suggest that you are probably dealing with dengue. Yes, there is no other illness with redness like that and a cold extremity. So it is a warning sign. You will have to take good care of such patients. I think if these two together are present in a child with fever, then they say the Suraj sign. That also I have found it is okay, it is there. In many children, you do find, the lateral upper aspect of the sole. And the lateral side, if you press that, is just like that increased capillary fragility only. You will find the blanching there. That I have noticed. I've seen in these children. These are signs, anywhere, sitting anywhere you can suspect dengue. Not only suspect. Coldness means there is no other illness, I think, which produces so much coldness so early. Evidence of a capillary leak. So such cases you will have to pay extra attention.
Yes, madam. We actually remember you telling us you have to fall on the feet of the patient, touch the feet of the patient and make a diagnosis.
മാഡത്തിന് ഓർമ്മയുണ്ടോന്ന് എനിക്ക് അറിയില്ല. ശരിക്കും എന്റെ PSC ഇന്റർവ്യൂവിൽ മാഡത്തിന്റെ ക്വസ്റ്റ്യൻ അതായിരുന്നു കേട്ടോ. വൺ ഓഫ് ദ ക്വസ്റ്റ്യൻസ് വാസ് യുവർ സൂറത്ത് സൈൻ.
Sherry, okay, thank you. Good night.
Thank you, madam. Thank you, madam.
Dr. Narayan,
Dr. Bala.
I think Bala can conclude.
Okay, Narayan sir is not there. Narayan sir is not there.
Narayan sir നോക്കിയിട്ട് കിട്ടിയില്ല.
Okay, we have a meeting at 8:30. Anyway, I will conclude in 2 minutes. I think the coming months, coming weeks, programs like this is very important. And first of all, let me thank IAP for obliging to the request of members of Kerala. Only 2 days before, I told Bennett sir and Priya about this program, and they immediately arranged the program today, Lepto and Dengue. Even our members, even if they hear all these topics from speakers like Dr. Sheeja and Dr. Anju repeatedly, I think it will be useful for them. As you all know, we will be in the April-May season. We will have, usually we don't have much patients, and in the June, suddenly a lot of cases comes and we'll be taken for surprise, and we should be very alert, especially pediatricians working in the periphery. So programs like this is very useful. I congratulate Dr. Sheeja and Dr. Anju, especially Dr. Anju, who is very difficult to present after a speaker like Sheeja, and she did very well, completed all the, yes, covered all the points. So thanks IAP Trivandrum and faculties for the wonderful show. Thank you.